Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perfusion, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EZ-Flow Duo. For arterial direct and venous femoral cannulation, the EZ-Flow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EZ-Flow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EZ-Flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
Hello, everyone, and welcome to our program this afternoon, Corona 30, Part 1, Day 5, and it's been a lot of fun thus far doing all of this. With us today, as you know, is going to be John Ingram, and we're going to explore farther the ECMO cannulations. I think he's going to be talking about some exotic cannulation, more complex cannulation, and I've got a couple of slides too, but I wanted to make one announcement, very important. Juan Carlos Vasquez from Argentina answered the question yesterday correctly, which was, why was that venous access line red? And he sent and said, because it's in the left atrium. And that is absolutely correct. So I'm sending 2 of these very, very fashionable perfweb.us cups to him down in Argentina, and we'll expect a picture from you drinking your morning coffee out of it, okay? So that's that. Now, how did it get to the left atrium from the femoral vein? Well, went up the femoral vein, went into the right atrium, went transeptal, and was draining the left atrium in that fashion. And that's a very popular way to decompress the left ventricle when you have patients on VA ECMO. So with that said, I think John might be talking about that as well. Before we get too much farther, I need to talk about our sponsors. So I'd like to thank LivaNova and Siemens. Both of them have been very generous with us, and we appreciate them so very much. Social media. I need you to like us on Facebook. And we've got a lot of Facebook activity. I'll tell you what, it's incredible at how much activity we have on Facebook. But like us on Facebook, follow us on the Twitter, share us on LinkedIn, make sure you subscribe to our YouTube channel. I want to get another 50,000 subscribers today in this next hour, okay? So I'm counting on every one of you out there. I'm sure we have 50,000 people watching from somewhere. And make sure you give us a thumbs up. No thumbs down, it's not allowed. Thumbs up only, okay? We appreciate that so very much. Check out our websites. We have perfweb.us and perfusioneducation.com. If you'd like to join our faculty and give a lecture on a topic you have, of course, content expert on, or you have a real interest in, a passion for, or maybe you have a case report that is very unique that you'd like to discuss and share with our audience, please reach out to us at that email address you see right there, contact@perfusioneducation.com. We would love to hear from you. Also, if you, on the Corona 30, keep in mind that we are providing financial support for anyone who might have, have a gross reduction in their salary. Perhaps their position got cut. They're a per diem perfusionist or locums perfusionist, and they haven't had any work for a while, but they still need their CEUs and no money to go to a meeting, but there aren't any meetings right now. Of course, you could join Perfusion Education, our library, for free, watch for free, but if you need the CEU certificates, there is a price associated with it. But if you need the financial support, we will give you all of the Corona 30 programming, which is 30 Category 1 CEUs by the ABCP at no charge to you. I think you saw our call-in number. We had it up there just a second ago. There it is right there. The phone lines will be open early, so feel free to call in if you'd like to. We'd love to put you live on the air. We'd love for that to become more popular. It really isn't too terribly popular yet, but hopefully it will. So with that said, let's bring John in. And John, good afternoon to you. Let's see, there he is. Hey, John.
Hey, good evening.
It's good to see you. It looks like you're at work today.
I'm at work.
Very good. We appreciate you taking some time out to do this. Can we hear him? Say something, John.
Can you hear me?
Yes, yeah, I can hear you fine. Okay. So, in deference to time, John is a seasoned perfusionist. He's an inventor. He's been published. He's given presentations. He's a huge contributor to our PerfWeb programs, has just a wealth of knowledge and experience. Appreciate so much his willingness to do this. So let's give our attention to John Ingram, and he's going to talk about maybe some more complex ECMO cannulation strategies than the basics from what we saw yesterday, since this is kind of a part 2 to that. So John, if that sounds good to you, please take the floor.
All right, Joe, thanks for having me back. And if you can, you're going to be controlling the slides like we did yesterday. They kind of walk through step by step, so I think you kind of get the hang of it. So today I called this part 2, really, from yesterday's ECMO basic cannulation strategies. Today I'm going to be talking about how can you optimize your ECMO? How can you optimize your ECMO therapy? And clearly ECMO is a very, very broad subject. We can't cover nearly everything, but I chose about 5 areas that hopefully you can be a better ECMO perfusionist, ECMO specialist, or nurse clinician, whatever your role is, at your facility doing ECMO, especially for those who aren't in the most busiest of centers. So Joe, I don't have any disclosures if you want to proceed there. So this is the 5 areas we're going to be talking about today. And Joe, feel free in the middle to pipe up and give your comments in the middle of the, like we did yesterday. I thought that worked really well. So first we're going to talk about ECMO monitoring. Can you do better? Can you up your game when it comes to monitoring your patients on ECMO? And number 2, we're going to talk about a lot what you hear about north-south syndrome. It goes by a multitude of names, but we're going to look at the physiology and how do you diagnose it. And later we're going to talk about what you can really do to fix it. Then we're going to talk about left ventricular distension. How do you intervene and how do you prevent a patient on ECMO from sitting there getting a distended left ventricle, which could be catastrophic and goes against what you're trying to do. And then we're going to talk about recirculation in the ECMO circuit. What is a perfusionist to do about it? How do you monitor it? And how can you minimize it or even prevent it? And I think that's a very lively topic because just about every form of VV ECMO, just about, with very few exceptions, experiences a significant amount of recirculation, more so than what people realize. And then finally, it's going to come all together in the last section there, and we're going to talk about using information from all those 4 topics above it. If you're providing the best support you can, how do you overcome difficulties and flows and pressures, and how do you improve your ECMO configuration, which Joe, you were just talking about, modifying the cannulation and things like that. So it'll come all together there in the end on part 5. So ECMO monitoring, so we're going to just kind of talk about 3 fairly basic monitoring strategies that if you employ all of them, I think you're going to find you're going to be much improved. And hopefully a lot of you are doing, if not at least 2 or 3 of these, hopefully all of them. But just simple pulse oximetry and the best way to use that on ECMO. Then we're going to talk about advanced hemodynamic monitoring, and I'm going to focus on the Hemosphere device today. And then infrared cerebral and somatic oximetry. That's the near-infrared spectroscopy that a lot of you are somewhat familiar with. And focusing this on those unique ECMO situations and how they can help you. And if you combine all three of these, I think you're going to see a benefit. So the pulse oximetry, usually referred to as SpO2, just in case some of you don't know, it basically determines oxygen saturation by shining actually two lights through the tissue. And it detects the light that comes back. One is a red light and one is an infrared red light, and it's absorbed by the blood. And depending on how much of the hemoglobin is oxygenated compared to how much hemoglobin is not oxygenated, the ratio of the amount of red light is absorbed compared to the infrared light that is absorbed. Those two things are compared, and the pulse ox gives you your number. Now, this is pulse dependent. If you don't have a pulse, if the patient does not have a pulse and it's constant flatline flow, you're not going to get a reading on a pulse ox. So you can have several different ways, and here at our center we use all of these. You can have a finger probe, you can have in the nasal, and you can have an earlobe. So just to give you some idea, there's different choices on how you can do this. On the monitor, when you're looking at pulse oximetry, okay, you see I circled there in red the 98. Normal for most people who are not on any type of oxygen would probably be more like 90 to 95, but our patients sometimes get higher than that because we're oxygenating for them. And as you can see, right next to the 98 on the screen is the patient's pulse. And like I said, if you had a flatline pulse, you're not going to get a reading on a pulse ox. So on ECMO, though, we kind of draw the line at about a pulse ox saturation of at least 85% or greater. If we get much below that, we start getting concerned about how we can improve things. So talking about the Hemosphere, this is a multi-parameter hemodynamic advanced monitor that does many different things, and it connects to a Swan-Ganz catheter, a multifaceted Swan-Ganz catheter, and can give you many things. And I'm not going to go through all of them, but I just want to give you some idea. I think probably every ECMO center is using this device or something similar, but for those of you who are not in the ECMO room every day, just to give you some idea and some of the things you can use this for, one of the things is it gives you a cardiac output. The next thing, go ahead, Joe, it's going to give you a cardiac index. And as you can see there, this patient's cardiac index is 1.8. It'll give you an SVR, so it gives you an idea of your systemic vascular resistance, and then also the mixed venous saturation, which is very important, by the way, because if you're using a CardioHelp, that SVO2 on your venous line is not representative of the patient's mixed venous saturation. And we need to think about that and hold that thought in our minds when we go through this conversation. And just something here I want to point out, because it's on the right side, it's a Swan-Ganz catheter, you can get right ventricular ejection fraction off of this device. So something pretty interesting there. Right ventricular function and malfunction often goes undiagnosed or misdiagnosed a lot of times in ECMO. So this device, you can do many, many things with it. But this is one way, if you expand your knowledge of this device, that you can really understand your ECMO patient sometimes a lot better. So now I'm going to talk about the near-infrared spectroscopy. A lot of you know it as NIRS. There's also Forthright, I think, made by Terumo. But at any rate, they have pads that you put, as you see on the left there. You can put these pads anywhere, but primarily it was developed for cerebral oximetry, use in cardiopulmonary bypass and in other situations. And in the normal range, you want to be on the reading on the monitor is a 55 to 80% number is normal on this NIRS device. So if you see the bottom there, it's telling you that regional tissue venous saturations are only detected in the superficial area of the cerebral cortex. Now, this is probably a company graphic, and that's a little generous. A lot of research has not been able to verify that it goes a whole lot deeper than the skull itself. So when you're reading these numbers, don't get the impression that you're seeing deep tissue brain perfusion. You're seeing very superficial surface capillary perfusion saturation. Just keep that in mind.
And John, it's mixed. It's
Right.
mixed with, it's arterial and venous. It's got to get through, skin and muscle and bone and tissue and other fluids that are there. Yeah, I gave a talk on this very thing. And I don't know how you feel about this, but one of my big concerns is if you're going to use it, then you need to use it, and you have to react to things that are that go out of whack. But I do think that I do question its validity. As far as just because the numbers are good doesn't mean everything's okay. Do you seem to feel the same way?
Yeah, you have to use this device, and that's exactly why I stopped and wanted to point out that this slide is indicating that you're really getting into the tissue of the brain, and a lot of studies have not shown that it goes much even past the skull, that you're really getting a lot of scalp and skin mixed capillary perfusion. Now, you can't use it as an authoritative number. If the more you use it, I think the more you get to know the device. And I do think it helps in trending for sure. The absolute number, you need to kind of mix with other factors while you're doing a case. But in ECMO, and I'm going to show you a little bit on this, combined with some of the other monitors, which is why I'm including this with some other things, it can be pretty valuable at times. So one of the things that I like about this particular monitor, though, is that you can use it anywhere. It doesn't have to be cerebral, and it does seem to work somewhat better on the limbs, especially if you put it over the muscle, like on the side of the calves, because you don't have, as in the cerebral, you don't have the bony skull that it has to try to go through as much. And so you can put on ECMO, I basically recommend this strategy most of the time, which would be a right and left forehead, and on anytime you have a femorally cannulated leg, a femoral artery, I would always recommend having the cannulated leg with a probe and a non-cannulated leg. And if you'll do these 4 probes going on at the same time especially, you will eventually learn, I think, to be a better ECMO perfusionist, because you'll start to see things that otherwise you may not have seen or noticed or even realized that was going on. We're going to look at some of those later. So in my opinion, if you have an arterial femoral cannulation, it's really a must, but you could use it on other ECMO cannulations as well. You'll learn some things. It does give you some immediate indications of regional hypoxia. You're going to see it pronounced in Harlequin syndrome or any limb that starts to be malperfused. It can give you ideas about malposition of cannula. It can give you ideas and indications pretty early on about poor cerebral perfusion. And I know from my experience in the OR, when we use this for cerebral, you can start to see drops if you have low flow states, if you have low carbon dioxide, if you have low hemoglobin, and if you have low flow, you can definitely see drops in this. And if you increase your carbon dioxide or increase your flow or certainly give blood, you'll see these cerebral SAT numbers jump right up most of the time. And also, so finally, if you use it on a limb, it's going to give you indications of poor limb perfusion. It's not an end-all, but it's a very helpful device. So this is kind of a nice picture of the screen of what you hope it would look like. Again, normal range that you want to shoot for 55 to 80%. And here's a pretty picture screen of the brochure probably. But anyway, it does give you good numbers. This would be a nice situation if you had this situation. But the interesting thing about this is if you look to the left and you see all the graphics, it's giving you the trends and it shows you the changes of where you were and whatever time frame you set the screen up for. And it can show you that at one point you were satting better or worse, and you can see where you are now, line by line. So that part of it I kind of like. It shows you a back trend of where you've been. Go ahead again. So this might be a more realistic patient. This is a patient. And again, you can see now where your numbers aren't so rosy. You have a left and right cerebral. You can see one isn't as quite as good as the other. And a lot of times you'll see that on a patient where one side on the left and right side of cerebral probes are not always the same. Now, a lot of this is position dependent. and as far as where you locate the device, but at least it gives you a good idea. And again, look at the trend on, for example, the one that says R58 there. You see that at one point, the saturation at the left side of the screen was fairly higher than it is at this moment. Same thing is true of the bottom one where it says 47. If you look back, it was somewhat higher, several hours ago. And you can see and ask yourself, well, what has changed? What has gone on different that this might be telling us something? So now I think the main thing is talking about north-south syndrome, okay? Now, people often talk about north-south syndrome or Harlequin syndrome, regional hypoxia, regional hypoxemia. It goes by a lot of different names. But a lot of people who don't do ECMO very often are not clear about what this is. So before there's any conversation about north-south syndrome, you must have two things in place or must be occurring in order for you to have any discussion about north-south syndrome. And number one is you must have a femoral arterial cannulation. If you don't have that, there's no conversation about north-south syndrome for the most part. And secondly, in addition to a femoral artery cannulation, you must have poor lung oxygenation or poor lung function. So when you have both of those things, you now can think and have an intelligent discussion about possibilities of north-south syndrome. So what happens is you have the left ventricle who maybe prior to this and while you went on ECMO in the first place was not ejecting very well at all. But now the heart is recovering and starting to eject. And if the lungs are not working very well, which is probably another reason why you went on VA ECMO, the heart is ejecting poorly oxygenated blood. So as you see there, coming out of the left ventricle, it's ejecting, but it's ejecting very low oxygenated blood because the lungs are failing. So now that poorly oxygenated blood is going to meet with the oxygenator retrograde flow coming up from the femoral artery, coming up the aorta. So when those two meet, it becomes a mix at that point, right? So that's what's happening there.
Yeah, I think they call that a mixing cloud.
Yep. Go ahead. So that point where it mixes, okay, is basically what Joe just said, and where that purple was, is the mixing cloud. And that's important because as you see here, if the mixing cloud is down in the abdominal aorta, you're going to have deoxygenated blood going up into the arch and basically causing brain hypoxia. And this is the real, concern about north-south syndrome. So basically what ends up happening is you can have cyanosis of the upper extremities while the lower extremities appear nice and perfused. So here, if you had your NIRS monitor, your infrared spectrometry on the 4 locations, as I mentioned earlier, okay, along with a pulse ox on the right hand, on the right finger, your pulse ox, that's the other one on the right finger there in purple, reading 67. And these are just numbers that I basically, made up for this talk. They could be anything, but you get the point. And that is that the cerebral and the right hand being a pulse ox down to 67. Remember, that should be 95 or so, and the cerebral oximetry should be 55 to 80, is way down to 38. Meanwhile, the lower limbs are nice at 71. So this is why it's important, and this is pretty much a pretty golden rule of ECMO. And I know this is a little bit of a messy slide, but if you look closely at any one of those, you'll see that in this north-south syndrome, depending on where the mixing cloud is and depending on where the arterial blood ends up higher towards the aortic valve or lower, this is going to reflect directly in a right radial or right brachial arterial line blood gas. So on femoral arterial ECMO, we always draw our blood gases from the right arm or the right radial. And actually, you should make that a practice all the time if you can. And you see there, like for example, in B on the left side of that graphic where the mixing cloud is way over close to the aortic valve, you're going to see that your arch vessels are perfused. Whereas if you look at number C next to the right of it, you're having a very poorly saturated right radial, which reflects your arch vessels perfusion.
Uh-oh, I think I did something wrong. Hold on. There we go.
There we go.
Sorry about
that.
that.
So next topic I want to talk about is left ventricular distension. Okay, and how do we prevent it and what do we do about it? So the first thing is it's really best diagnosed under echocardiography. And if we have any question in our ECMO center that this is going on, we immediately get a bedside echo, and you can see the distension of the left ventricle almost right away. This is a pretty exaggerated example of it, but the echocardiographer can freeze the frame and do an exact measurement of the interior diameter of the left ventricle. And in the meantime of that, you should always be monitoring your pulmonary capillary wedge pressure. Everybody listening probably has a good understanding that on a Swan-Ganz, which is going to be in because you have your hemisphere monitor hooked up to it, you can take the Swan-Ganz catheter as far as you can, inflate the balloon into the capillary, and now it's basically going to get a direct reflection back from the pulmonary veins, which are connected directly to the left atrium. So that's why it gives you a pretty good left atrial pressure. And you have to keep in mind, normal left atrial pressure is somewhere between 4 and 12. Many times we see much higher than that. And that's telling you something. So what can we do about this? Lots of times patients come to us, they already have an impella. An impella is an axial pump on the tip of a catheter, and it's fed into, usually up the femoral artery, past the aortic valve, and the inlet drops right into the center, generally the center or the apex area of the left ventricle, and the outlet is way up just past the aortic valve. So basically, it's a nice way to propel blood. You can go 3 or 4 liters with these, or more sometimes, depending on the size that you put in. And it's a constant flow, by the way. This is non-pulsatile, but it is a great way to act as an LVAD, and a lot of times that's why people put it in. But if that is not enough support, the patient may come to us and end up on ECMO, in which case we almost always leave it in because now it's a great way to eliminate and reduce left ventricular distension. So it becomes a great tool when that happens. Well, if that's not enough or that didn't happen, we do this often as well, and that is you can put a cannula right into the apex of the left ventricle. You can do it without opening the chest. You can do it from under the ribs, but here's an example of a left ventricular. You're on central cannulation, VA ECMO, right atrial to aorta there in the picture, and a left ventricular cannula placed right into the apex. And we're going to drain that cannula. It's going to be wide into the venous drainage line, and all that blood is just going to come right back with your venous blood and back into your ECMO. So this slide's a little busy, but I tried to highlight it with each time of the red circle there. So there's a variety of ways that you can drain or reduce the distension of the left ventricle, okay? So one is an intra-aortic balloon pump. An intra-aortic balloon pump is going to offload, and that's going to be somewhat helpful. Go ahead, Joe. And so you can also do an impella device right there. You can also put a catheter across the aortic valve that actually is connected to your drain again of your ECMO and empty the left ventricle that way. We don't see that too often. Now on the right side, you can do a surgical insertion of a catheter into the left atrium directly, usually right into the pulmonary vein most often. You can also do what I was showing earlier, where you put a catheter right into the apex of the left ventricle. And again, these will be drain cannulas. Go ahead. Now, something interesting you can do, we don't see it too often, but you can actually create an intra-atrial septostomy if you have a lot of drainage in your right atrium because you have a nice venous drainage located in the right atrium, and you have a very full left atrium because your left ventricle is distended, and you open the opening in the atrial septum, you can have a lot of drainage coming right from the left atrium over into the very low negative area of the right atrium and empty it that way. We don't see that too often with adults. Then you can have, you can cannulate the pulmonary artery. You can put a cannula right there where it says PA in the drawing there, and you stick a cannula right in the root of the pulmonary artery. And again, this would be a drain cannula, and you could directly drain the pulmonary artery. So you're accomplishing the same thing because you're capturing the blood before it even goes around the lungs and ends up coming back into the left side. Okay, so why did I say all this? There's
Much.
two huge things that I want you guys to take home with you today. When it comes to left ventricular distension and drainage, okay, when you run into a shift and you go into an ECMO shift and somebody rattles off all these alphabet soup that the patient is cannulated, VV, VA, and all this crazy, and you're wondering yourself, well, why is that, and what are all these cannulas doing? When you see an ECMO hybrid situation, the first question I want you to ask yourself, and this is going to help simplify it, is the purpose of any of these cannulas, is the purpose to reduce left ventricular distension? And you will be able to take that one cannula and say, okay, I see why there's a left atrial cannula or a left ventricular cannula. All that's doing is drainage. It's a left ventricular vent coming into my venous line. So you can compartmentalize that. Now you've simplified it. Now you can focus on the other two or so cannulas. So that's question number one you want to keep in mind. Go ahead, Joe. So let's talk about another section here called recirculation. So recirculation, basically, what is it? It means that a portion of your oxygenated blood is coming back into the ECMO circuit instead of going on to the patient. So this does not benefit in patient oxygenation. And
Stream is up. Yep, we're good. Okay, hold on. It's still loading over here. So we're back? Okay. You sure? Yeah, okay. All right, everyone. Sorry about that. We had a little technical glitch. We got it fixed. John, go ahead. I think we can bring John back and go back. And it was a perfect time for it to happen. So consider it our break for the day.
So are we good? You guys hear me okay? Okay.
We can hear you.
Yeah. Basically recirculation is blood that's intended to go into the patient. Some of that is making its way from the reinfusion arterialized blood cannula back into your venous return cannula. A certain percentage of that is coming back, so that's not beneficial to the patient. That's what we call the recirculation fraction. Go ahead. So what are some of the factors that affect recirculation? The type of cannula, the position that it's in, the amount of pump flow. We can spend more time on this one day, but you can overflow your patient at some point. If you overflow the more than the patient needs, some of that is forced to be recirculated. We can talk about that. Volume status of the patient can play a role. If the patient's overstuffed, basically you can have more recirculation. Cardiac function is going to matter because depending on how much the heart is able to move the blood forward, will less time for recirculation to occur. And then the patient position, if the patient's up on one side or the other, the venous cannulas can shift and be recirculating even more. So just to give you some idea that there's some other things, but there's four big factors that affect what we're trying to do in ECMO, which is oxygenate the patient, right? Well, one is the amount of blood flow and amount of flow that you have, and that works as much drainage as you can get, and how much positive pressure you have to push against. But your amount of blood flow is obviously a big factor. The percentage of oxygen, your FiO2 that you're putting through the membrane, is going to affect what you're doing. And then the membrane itself, the efficiency, the functionality of the oxygenator is obviously a big role. And then the fourth one is recirculation. So as you can see, recirculation is one of the big four factors that affects and limits your ability to oxygenate the patient. Go ahead, Joe. So basically, I'm not going to spend too much time on this particular slide, but as you can see, you have blood that's intended to go forward to the patient, the oxygenated blood, and some of it is coming back to your venous line. And if you take these two, you can actually figure out what percentage of that blood is being recirculated. Go ahead, Joe. So real quick, if you want to do a quick calculation on your ECMO circuit, and by the way, this only applies to VV ECMO. If you look at if you need to get the patient's SpO2, the actual SpO2 from the Swan-Ganz catheter, not from your venous probe on your CardioHelp. The venous probe on your CardioHelp is not a patient's SpO2. So if you get the patient's SpO2, then all you have to do is get your saturation, pre-oxygenator and post-oxygenator saturation. So I gave you an example there on the right. Let's say your patient's SpO2 is normal at 74%, and your pre-oxygenation SpO2 is 81%, and then your post is going to be, 99%. So if you just subtract those, you'll see 81 minus 74 is 7, 99 minus 74 is 25. That's a situation where you have 28% of your flow is being recirculated, and that would not be uncommon. Go ahead, Joe. You got me, Joe? Go ahead.
Yeah, I got you. Yeah, that's a very simple formula, but there are, a lot of places who use, I'm actually going to be giving this talk, John, that use less invasive hemodynamic monitoring and don't use the SWAN, because
go
that
to the
does.
Next slide. I think you'll see that.
Yeah, and good. Okay, yeah, because let me see. Let me go to the next slide. I'll stop. Okay.
Yeah, I just wanted to.
There
show
it is.
people.
Okay, that's what I was going to say, John. I read your mind.
I know. Yeah. Well, I just wanted to show people that you'd have to get a true mixed venous saturation from the SWAN. And by the way, that may not be possible if you have atrial cannulation, which you are talking about VV ECMO here. Your SWAN venous saturation may be inaccurate as well.
That's
so
right.
You may not even be able to calculate it. And so just to show it looks good on paper, but in actuality, you still may not be able to calculate it very easy, if at all. So, and I know this is a favorite topic of yours, and I like this topic too, Joe, the transonic ELSA monitor that's out there. You can talk about this, we can go back and forth a little bit, but it's a simple monitor with two simple probes, and all it involves is putting a probe on your venous line and on your return line.
Yes, and a simple, for an adult, 20 cc's bolus of saline, and it really works well. Here, there's your numbers.
That's similar to the slide I think you and I were talking about yesterday. On the left there, you just put the probe on your inflow line to your ECMO, to your ECMO circuit, and then the outflow line that you're delivering arterialized blood back. And you hook a 20 cc syringe, I think it is for adults, you inject saline, and this is going to calculate the amount of saline that gets recirculated back. And in this particular illustration here, probably was a pediatric, but they were trying to flow 1,647 cc's a minute, but their effective flow was only 1,301 because they had a recirculation of 21%.
Yep.
And this device, by the way, if you're a big center, you don't have to buy one of these devices for every patient. You can go around and just move this from patient to patient to patient once a shift and get your idea what your recirculations are.
Absolutely, absolutely. And they're very, and they're really very for what it does. Not just recirculation, but also oxygenated blood volume, which I think is very important too, to identify early clotting of your oxygenator before you see any real degradation. You can see the trend and know you're not heparinizing well enough. That it's a good early warning system, but it's very affordable. It really is a very affordable device for what it does.
Is, Joe, there's no disposable. It's a one-time expense.
Correct.
You buy the machine, I think it's about $30,000, and that's it. You can have it for years and years and never have to buy a single disposable. You just take this probes on and off and go around to each of your patients, and every day or even every shift, and see what your recirculation is. Because remember, this recirculation is hurting you. It's hurting the very thing that you put the patient on ECMO for, which is oxygenation support.
Absolutely. 100 couldn't agree with you more. But it's really interesting because this company, they also have a device that hooks up to the intermittent dialysis. They can put it in the dialysis centers, and it will tell them what the quality of their fistulas or AV grafts are that they're doing the dialysis through, and is a terrific early warning signal that your fistula or your graft is going down. Your dialysis access is starting to break down or stenose.
And the other amazing thing, which is not on this topic, but real quick, this also tells you the clot load in your membrane oxygenator. And we know all of our CardioHelp's oxygenators all have clots, 100%, whenever they've done a study.
Well,
and this will tell you how much percentage of your oxygenator is being dormant due to clot internal that you can't see.
Well, who came up with the brilliant idea of having a square oxygenator with 4 corners?
Yeah.
I don't know what in the body ever has right angles, but I guess that does. So
So what's a perfusionist to do about this recirculation? Well, I think you should monitor it if you can get one of these monitors, or at least try to calculate or monitor it with some frequency so you have an idea of what's going on. And then there's some things you can try to do. One of them is adjust the flow rate. Sometimes if you're overflowing your patient, in other words, if you're doing VV and you're flowing, 5 liters a minute, but the patient's cardiac output is only 4 liters a minute, there's only 4 liters a minute that's being sent out of the right atrium to the patient, and you're trying to recirculate at 5, which means a lot of that blood is going to be recirculated, and you're going to see very high SpO2s on your venous probe on your cardio health or whatever venous probe you're using. So I've seen this before where we didn't understand what was happening, and we actually turned the flow down, and we realized we were overflowing the patient, overflowing the cannulas. You can try repositioning the cannulas. You can try repositioning the patient. I don't really have too much experience with repositioning the patient, but sometimes it's because the patient's lying on his side and needs to come back flat.
I'm sorry, John. We're just having technical difficulties today with heat, but we're working on it. So we apologize to everybody who's watching that we're having these technical problems. But we're working on it. Okay. So with that said, John, go ahead and continue. I'm sorry. You may want to start over with that slide.
Yeah. So if you're seeing recirculation, which with VD ECMO you almost certainly are, try to monitor it, calculate it, get an ELSA monitor, so you can get an idea of how inefficient you're actually being. If your surgeon comes up to you and says, why aren't we supporting this patient? We're flowing 5 liters. You might be recirculating 30 to 40%, and that would be a simple fix and a great way to show that you're on top of it. Adjusting your flow rate, and you'd have to watch your numbers change when you do that to see if you're improving. Repositioning of cannulas and the patient, as I said, and then perhaps even changing to a dual lumen cannula if possible, away from a 2 cannula system, which 2 cannulas may be facing each other or very close to each other and intermixing. So now here's where hopefully the whole lecture comes together, with using everything I've just talked about to see what's going on with your patient, and it becomes very clear, and it'll help you understand those complicated cannulations and things that are going on. This will definitely make you a better ECMO perfusionist if you take some notes in this part right here. So you're having poor support. How can we improve our flows, pressures, and our cannula configurations or ECMO configurations? So what I've done here, if you start on the left, this is our patient lying on the bed, our ECMO patient, and you'll see the little blue squares. Those are our near spectrometry, and I put numbers up there that gives you the readings of what it might be reading on this patient. And on the right finger there is our SpO2, our pulse ox. And right now, everything's normal. If you look at the top middle, the ECMO parameters, and I'm not going to be changing a lot of these, but basically we have a decent RPM and a decent flow and a decent map. Right now, everything's looking good. Minus venous pressure, minus 65, decent arterial pressure in our A line. Patient's SpO2 is 74. So if you look at the status, now this particular patient is VA ECMO. We're centrally cannulated on this patient, and we're cannulated with the right atrium and the aorta, okay? And right now the patient's condition is stable. So go ahead, Joe. So what happens now is that the time for the nurses to give the patients their bath. Turn them on one side, clean them all up, turn them on the other side, clean them all up, lay them back down. Now, I've witnessed this more than once at our center. And all of a sudden, the saturations have changed. The patient's cerebral sats have dropped from way down from 65 to 45. The pulse ox is also down from 95 to 68. Okay, so what's going on here? What is the issue? Well, we're seeing low pulse ox and we're seeing low cerebral saturations. Nothing with the ECMO's changed. All we've done is turn the patient side to side like they do every night. So what's going on here? Go ahead, Joe. So what's happened here is, and I've seen this on 2 occasions, a lot of times when you do central cannulation with ECMO, it'll be a long tip aortic catheter or aortic cannula. And if you turn the patient, it's pretty easy for that cannula to be shoved or moved ever so slightly further down the aortic arch. This can create a big drop in your arch vessel perfusion. And this has happened twice here. And basically, the cannula needs to be pulled back and repositioned and put the way it was. But it can be frightening if you have no idea what's going on. You don't know if the patient's stroked. You don't understand why. You're doing central cannulation. You should have great perfusion. And we've seen this on more than one occasion just by moving the patient. Go ahead. So now let's look at another case. This, if you look at the status there, our ECMO numbers are the same. We're starting with a normal, stable patient, and our spectroscopy numbers are the same, and the pulse ox are all good. This is a peripheral cannulation, though. Left femoral vein, right femoral artery. Straightforward. A lot of people have seen this. Right now, the patient's stable. Go ahead. So then, all of a sudden, look at the right lower limb becomes the spectroscopy saturation has dropped way down from 60 to 43. We have this right lower limb ischemia with a low saturation. Nothing else has changed. Well, go ahead, Joe. So what is the cause of this? Well, we have patients sometimes who come from other centers. It was a crash and send type of ECMO. We get them. They didn't have time to put in a distal perfusion catheter. That can happen, or you have a distal perfusion catheter that stops flowing for some reason, kinked, clotted, obstructed. So this, when you have the spectroscopy 4-probe assessment like I'm asking you to do, you'll see these things right away. And so you need to either put in a distal perfusion catheter or flush or fix the one that you have. And you know, just feeling the temperature of 1 foot to the next and doing that every 4 to 6 hours is going to be a far less prompt diagnosis than seeing it moment to moment on your spectroscopy meter. And so what you would need to do is insert a distal perfusion catheter, and there's several different ways this can be done. If you're not familiar with it, you put a small 5/6 French catheter facing down towards the foot, and you just use a luer fitting with a small tubing to connect it right off the luer of your arterial connector. So here we have another case. Okay, and what's happening here, look at the status, the VA ECMO, peripheral cannulation again, same cannulation, left femoral vein, right femoral artery, and right now the patient is stable. All of your SAT numbers over there on the left are good. And this patient, just so you know, is on VA ECMO because of severe respiratory and cardiac failure. So we ended up having them on VA ECMO. Go ahead. So now if you see, after a while, we've been doing fine, maybe 2 or 3 days, no changes, hardly at all. And all of a sudden, one day, we're starting to have a saturations drop. They drop, cerebral saturations drop. The right pulse ox is dropped way down from 90 to 70. What's going on? Why are we not perfusing the brain? Are we having a stroke? Do we have a dissection of the aorta? What's happening? Well, as you can see, your limb sats, your lower limb sats are still normal, okay? And basically, you can see here that what you're having is more activity and function as the left ventricle is starting to contract better. You've been resting the patient for several days. That was the point, to rest the left ventricle. The heart's starting to eject now. Well, the lungs aren't better, though. The lungs are very poorly functioning, and you're not getting oxygenated blood around to the left ventricle. As that left ventricle starts to pump, you get what's now called north-south syndrome, okay? So we're going to look at the solution a little bit more elaborate on this one, okay? So we have north-south syndrome. What is the correct intervention? What do you do about it? Well, there's 3 things you can do. The first 2 are sometimes not so great, most of the time not that great. But one thing you can try to do is increase your flow. Remember, you're flowing retrograde up the aorta, so you can try to push that mixing cloud up to at least midway to the aortic arch. See, what you're doing there on the left is that you push the mixing cloud to at least to the left subclavian takeoff, right? So you're getting the left carotid perfused, not so great on the right carotid. So unfortunately, though, the problem with this idea is that the very heart that you're trying to rest and recuperate, you're now stuffing blood back into it. So it often results in left ventricular distension. And by the way, if there's any amount of aortic insufficiency at all, this is going to be even more exacerbated. So this is a nice try, but you gotta be careful about left ventricular distension. You can try increasing the vent. Well, again, unfortunately, you're trying to rest the lungs. So if you have some room to increase the ventilator that's maybe set very low and you have some room to come up, then maybe you can try that. But again, you have to be careful that you're not being counterproductive to the whole process of resting the lungs. So number 3, go ahead, Joe. So number 3, this is what we do very often at our institution is we go ahead and we really don't hesitate and we add another cannula, okay? And we're going to convert this patient who is VA to VAV ECMO, and we're going to add an additional return cannula into the right atrium. Now, this is a return cannula delivering oxygenated blood into the right atrium. So now what makes its way over to the left ventricle is already going to be pre-oxygenated, okay? So here's one thing about this, though. You just don't put this cannula in wide into your arterial line and you're done. Because think about it for a minute. The pressure in the right femoral artery, or I guess this case is the left that shows in the diagram, is much, much higher than what is in the right atrium. So you're going to get an overabundance of flow going into the right atrium and very little flow into the right femoral artery just because of the path of least resistance. So you have to put a Hoffman clamp down on that line leading to the left atrium and a separate flow probe monitor and monitor.
We're back. Well, everybody, I'm sorry again for the difficulty. We're really having some technical glitches today. It's tough sometimes over here. It's hot today. We need a bigger air conditioner in the studio. The box gets super hot, and then it has a heat sink in it, or some kind of a heat protector rather. And when the box gets so hot, it shuts down. So I think they're going to try to control the graphics and reduce that, and hopefully that'll help get us through this. So again, everybody, I apologize for it. As soon as we have John back, let me know, and I'll get him back going again. I think I see him now. Okay, you're up, John. Again, I'm really sorry.
It's okay. So I think we were saying that when you put this additional right atrial cannula in, the resistance is much, much lower in the right atrium compared to that of the femoral artery, and you're going to get a huge amount of flow wanting to go up the right atrium. So you must limit it with some type of Hoffman clamp, and then you don't know what's going there, so you have to put a flow probe and monitor it. But the nice thing about VAV ECMO that I really like is you have now some respiratory assistance, some pulmonary support, and cardiac support. You have a little bit of both. And as the patient improves, gets better or worse, you can modify how much VV ECMO you have and how much VA ECMO you want to have. And you can go with it's like a gas pedal and a clutch. You know, you can do more of one or less of the other as you need to. So the nice thing about this, I prefer this type of ECMO a lot, because as patients change, maybe their lungs are getting better. Then all of a sudden one night, as you've seen many times, Joe, the lungs just go white on you.
Yep.
Or just have a bad night.
They always get worse before they get better.
VV support.
Yes.
You know, and you can do that with this. You can open up that Hoffman clamp. Let's say you're flowing 6 liters and you have 2 going to the right atrium and 4 going up the femoral artery. Well, all of a sudden, you know, the lungs are getting better, so you're doing good, but then the lungs have a bad night, they white out, and you can do more to the VV side and open up that right atrial flow and decrease some on your femoral artery. So I like this form of ECMO a lot.
John, would you, as far as measuring the flows, you know, obviously the Hoffman clamp is going to help modulate the flow to the direction you want, but, you know, most ECMOs only have one flow probe, so do you switch it back and forth? And if you do that, which one do you tend to leave it on preferentially?
Well, we have the luxury of having a lot of Centromag units here, so we'll bring in a Centromag and turn it on just for the ability to watch the flow, and that way we'll leave it on there all the time.
Okay, so if you didn't have
that luxury, you might have to do what you said, and every so often, you know, check it out and see. But usually it can stay pretty steady. But then again, if your blood pressure is changing, your SVR is changing. One reason I brought that up on the monitoring thing was that you know, if your SVR changes, now this might affect this particular form of ECMO because you might get less going down the femoral artery and automatically more down the right atrial. And if you don't have a flow probe on there, you're not seeing that happen. So you ask a good point. I've always done it where we had a permanent flow probe just on that line.
But if you only had one, John, my question is, which one would you preferentially leave it on?
Oh, I'd leave it on the atrial line. I'd leave it on the atrial line because the cardial help or the flow that you're using, like I said, let's just say you have it at 6 liters and you never want to, you know, over distend the right side. So you'll see, you know, let's say 2 liters going down the right atrium. You know the other 4 is going up the femoral artery. You know what I mean? You know by simple subtraction.
Okay, that's fair.
So,
okay, fair enough.
I don't think it really matters that much. I think you could do either one.
Okay,
but,
fair enough.
So the other thing you can do, though, besides putting a right atrial return cannula in, is you could put in a axillary cannula. And this would now be as close as you can get to centrally cannulating the patient without opening the chest. And so it would look like this. You have to sew a graft into the side of the axillary cannula. And we've done this many times. And you can now have the same VA ECMO that you had, Veno-Arterial, and basically now you've eliminated your north-south syndrome because you're perfusing right into the arch. And so you're having oxygenated blood going right into the arch, which was the whole problem in the first place.
Do you have any concerns, and what do you guys do in terms of preventing the flow perhaps from going down the arm and getting some distension of the limb?
Well, that's a very big concern, and we do great things to prevent that, actually. And I thought about making a slide for this. You absolutely have to. Now, you don't have to do this for normal cardiopulmonary bypass axillary cannulation. Usually you don't because you're only on perfusion for an hour or 2. However, in ECMO, that would be grossly unacceptable. When you do an ECMO cannulation axillary, what you must do before you do the axillary cannulation, you must have a right radial pressure line and you must also have a left radial pressure line up and working. When you go to do your axillary cannulation, you have to then take a loop, vessel loop, or a vessel tie from where the cannula is located there towards the shoulder. You must wrap a vessel loop tie and gradually restrict down on that until your pressures in the right and the left radial artery are the same. You go on ECMO for days and weeks at a time and you haven't restricted the flow to the right arm, you're going to have a severe complication to that right arm. So you do have to know what you're doing and be skilled to do axillary cannulation, in my view. So here's the solution, and we're back to where we started with these slides. At the bottom there, add a venous return infusion cannulary catheter or add an axillary arterial cannula. And by the way, go ahead, Joe. So now our last scenario here is we had a normal patient with all the normal numbers, as we always have, but this patient is suddenly becoming unstable. Now, as you can see in red there, cerebral sats have dropped down from 65 to 45. The leg sats are down from 65 or 70 to 50. The pulse ox is down. This whole patient is becoming malperfused, and our biggest problem is we can't flow enough. Why can't we not flow enough? Well, our negative venous pressure is our limiting factor. It's not because the arterial line pressure is too high. It's still 225. We cannot flow anymore. We're only flowing 3 liters. The blood pressure is not doing well. The patient's lactates are climbing, becoming unstable because we have too high of a negative venous line pressure, and we now have inadequate support.
Can I guess what you have to do?
Oh yeah, you got to do something about this. That's for sure.
Can I guess?
Go ahead.
Add another access.
Correct, and that's
Oh,
exactly
good.
why I'm bringing this up. If you have inadequate venous return because you have some sort of occlusion, clot, or maybe just the cannula was too small and it's occurring, actually being sucked against the walls of the vena cava or something along those lines, you need to increase your access. You need to increase your venous return. And I know this sounds simple, but I bring this up for a reason. Go ahead, Joe. I'm going to show you why. So now, if you have a a femoral vein, femoral arterial cannulation, as I said, now look at up at the status. We've now added a second venous cannula, either a second femoral vein in the other side of the leg, or a right internal jugular venous cannula. We've added that, and we've wired that into our venous line, or drainage line, but now we've converted the patient over to VVA ECMO. Okay, two drainage lines and one arterial return line.
Yeah, just as a reminder, you talked about that yesterday, and the dash is where the return begins.
Where the oxygenator is, correct.
Right, where the oxygenator is, right.
So that's maybe it's obvious to a lot of people, but if you're not somebody who understands some of the nomenclature and somebody rattles off alphabet soup to you because you've got 4 or 5 letters coming at you that you're going to watch this patient on ECMO, the first thing you want to know is look at where the dash is, because on the left side, those are all my drain or my access cannulas, and then past the oxygenator, that's where I'm sending all my arterialized blood back to. And then you have to look at from there. So I think that's our 4 scenarios. So what does all this mean? Why have I gone through all of this? Go ahead, Joe. What this means, first of all, when you're presented with a complicated cannula situation, the first question, as I said before, this is a repeat slide, you need to ask yourself, is the purpose of any one of these cannulas a drain, a left ventricular vent cannula for the purpose of reducing left ventricular distension? Most of the time, you'll be able to take one of those cannulas and box that in your mind and say, okay, that's a simple answer right there. That cannula, it's in the left atrium, it's in the pulmonary artery, it's in the left ventricle, whatever it is, that's just being a left ventricular vent, something we're all familiar with in the OR in one form or another. Go ahead. So the second thing, if it's just these 2 questions you focus on, I think will answer all your questions. When you're presented with a complex ECMO cannulation scenario, the second question I want you to ask yourself is the purpose of any of these cannulas was to overcome high pressures, either positive or negative, in order to increase our flow, okay? And you see all those myriad of, it's kind of hard to read that graphic, all these different types of cannulation scenarios. Don't confuse yourself. They're either, one is for left ventricular drainage for lack of distension, reduction in distension, or the other ones have been put in order to increase and overcome a high negative or positive arterial pressure, and that's why these added cannulas have come about. And that will answer all of your questions. So what does all this mean? Yes, those cannulas are doing one or both of those things. Left ventricular drain or increasing and overcoming a limiting high negative or positive flow cannula. Okay, so here's our summary slide and the key points. What you should do if you want to be a better ECMO perfusionist, employ a wide spectrum of ECMO and patient monitoring strategy, such as I've lined out or something similar. Perform frequent assessments of your recirculation when it comes to VV ECMO. Keep watch on how much is recirculating. Be very cognizant of north-south syndrome whenever you have a femoral arterial VA ECMO, okay? Perform frequent assessments of your left ventricular distension and the status of what's going on with your left ventricle. An unmonitored and left ventricular distension could lead to death to the patient. You're just very damaging to the patient to be distended and motionless.
Well, you know, you have to worry about LV thrombus. You have to worry about, of course, you know, as you increase wall tension, the circulation, the microcirculation of the myocardium is compromised significantly, and the worse the distension, the worse it is. We all understand that, you know, it's striated, myocardial muscle is striated muscle, and if you distend it far enough, it never comes back. So there's a lot of bad things that can happen with gross LV distension. There is no doubt about that.
And all of us have experienced as perfusionists, when the chest is open, the surgeon's standing up there, they don't tolerate 20 seconds, 10 seconds of LV distension. If there's ever a situation where the heart is too full, what does that surgeon say? Heart's too full. If you're doing cardioplegia and the heart is distending, they're going to let you know right away. With ECMO, the chest is closed most of the time. There's nobody looking at this.
Right.
This can sneak up on you and happen for, forget about seconds or minutes. It can happen for hours or days. Imagine the damage that you can cause. So that's why I say perform frequent assessments of LV distension. Keep a watch on your pulmonary capillary wedge pressures. That's usually a first sign giveaway, among other things that you can look at.
And I think echo as well. I think you should be doing, daily echoes. And if you have any suspicion at all that you are starting to experience LV distension, you have to check you have to do an echo. Because you're right, you cannot leave that for any length of time and not have serious consequences later on.
And Joe, it goes, we'd be remiss without mentioning that you have to think about a right ventricular distension also. The same thing can happen. So you need to think about, don't just isolate in your mind, got to worry about the left ventricle all the time. Right ventricular distension, pulmonary hypertension, very damaging as well. Getting back to the thing I probably just repeated a couple of times, the key points is ask yourself those two questions when you're trying to understand how did all this elaborate cannulation come apart. One of the cannulas is likely just due to a left ventricular event, and the others were probably due to improving a high pressure situation, whether it be negative or positive, in order to increase flow and better support the patient. I think that is probably the last.
Oh, very good. Yeah, we made it through without blowing up again. It's been a rough day, John. It's been a hard day at Half Pond Studios, MediWeb Studios. Let me tell you, but it's just part of the game, and we'll have to fix this problem too. I'm on my way to Home Depot or Lowe's after this and buy yet a bigger portable air conditioner to blow into the box. Eventually, one of these days, when we get all of the sponsors that I've been hoping to get, we'll actually be able to afford a bigger air conditioner central and be able to not have these problems. But anyway, with that said, that was an excellent presentation. Very, very good. And if you would indulge me just for a moment, and by the way, the phone lines are open. He's not going to put the graphic up, because if he puts the graphic up, we're going to just stress the box. We don't need any issues right now. I'm just telling everybody, if you want to call in, you know what the number. What's the number? 832. What's the number? What's the number, Magic? Yeah, hold on. It's 832 239 5358. So you can go back and reverse this and find it if you want to. And Magic's going to type it in. But can you throw my slides up by any chance, or would that be too much? Let's see. Yeah, there's my slides. So do you remember this from yesterday, John? Hold on. Yeah, there you go. Do you remember that from yesterday?
Yeah, and it's a bit of a head scratcher. It's a good question.
So in your case, so what would you do in this case?
Well, let's see here. So you have a 26-year-old female, poor ejection fraction, and fulminating pulmonary edema. So, we actually had a couple patients like this, but it was such an emergency crash that I don't think there was time to do anything other than what we did. So I won't elaborate on that. But in this case, my concern is poor left ventricular ejection and the fact that you're having such severe pulmonary edema that I would want to do something to completely compensate and support the patient without, and hopefully relieving that pulmonary edema, without aggravating the pulmonary edema, and certainly offloading the left atrium, the left ventricle, so that we could have no more backup into the pulmonary side. So, I would definitely do VA ECMO because the ejection fraction is only 20%, and you have poor contractility with obviously poor functioning pulmonary. So I do some form of a VA ECMO, and I think I would vent the left atrium or left ventricle to make sure that I could eliminate any more back pressure into the lungs. Those are the first thoughts that I would have.
Those are all, I mean, I think those are excellent thoughts. And I felt, much the same way. Now, I didn't do this case myself, but they were telling me about it, and my team did it and did an exquisite job on it. But let me go.
Can I throw one more thing in? I'm going to go out on the limb here.
Yes.
It wouldn't totally shock me if they opened this patient's chest and went on central. That's probably a bit radical, very radical.
Yep.
But if you told me that happened, I would be, a little bit eyebrow raised, but it wouldn't totally shock me if that's what they ended up doing. I hope maybe they didn't, but.
No, they didn't. So let me go back to this slide. We looked at this slide, and I think that this slide dovetails very, very nicely into your presentation today. So we have refractory hypoxemia. We have cardiogenic shock. Now this is where it got real tricky. The pulmonary edema was just from LV failure, is what it was from. The question is the cardiogenic shock directly related to hypoxemia, or is the cardiogenic shock related to some other cause? And this is where the surgeon, Dr. Mark Matoyer, great guy, he made he made a judgment call on this, and he went on VV ECMO. Okay, so we went Veno-Venous ECMO right here. So due to hypoxemia, right here, Veno-Venous ECMO right here. And so they did the C-section. They were getting ready to resuscitate the patient. They got the baby out, gave the heparin, went on VV ECMO, and as soon as going on VV ECMO and oxygenating her cardiogenic shock state started reversing very rapidly. She was on ECMO for 48 hours, came off ECMO, went home, her, the baby were fine, and everybody did great. So actually, the decision was less invasive, although I think VA ECMO would have been a very reasonable thing to do. And it could have gone either way.
Yeah.
However, he was very certain that this young woman's cardiogenic shock was secondary to hypoxemia only, and reversing that was going to reverse her cardiac dysfunction. Now, if it didn't, certainly we could have added an arterial cannula there as well, but the decision was made, and it ended up being the right decision. So she did great.
Joe, this was a great slide you put up, and if anybody watched my presentation from yesterday, about a third or so away from the beginning, I discussed VV ECMO and the indications for VV ECMO, and we made mention to the fact that VV ECMO is exclusively for pulmonary failure. However, and we say it has no cardiac or circulatory support. However, in the case of a person who's hypoxic and is getting poor perfusion down their coronaries, and now is secondary having cardiac failure, VV ECMO indirectly and not so indirectly does support cardiac function because of exactly what you're talking about here. We actually talked about that yesterday.
We did, and I remember it very well, and you're exactly right. If the cardiac dysfunction is secondary solely to a lack of oxygenated blood going down the coronaries, and you can fix that problem, then the heart, unless it's been damaged beyond repair, should recover very quickly.
Well, now that you say that, Dr. Matoyer, I can see that he's thinking this is a otherwise healthy 26-year-old woman. Her heart is probably banging. Why it's at ejection fraction of 20% is most likely secondary to the hypoxemia and not due to coronary artery disease or an infarct or some type of cardiomyopathy. So knowing that, it does make sense that he did that, and that's why it worked.
Although, you know, John, the youngest patient that I ever that ran the pump for that needed coronary bypass surgery, the youngest patient was a 26-year-old female.
Yeah.
Who had
I've seen
severe multivessel coronary artery disease.
Yeah, I've seen that too. But you see what Dr. Matoyer did. The odds of her heart being fine were 99% versus what you just mentioned, which does exist out there. And he probably, you know, had a fair idea that the woman was, you know, her heart was in good condition and needed oxygen.
Yeah, she was otherwise she came in as an otherwise healthy individual, and it was just severe preeclampsia and you know, hypertension and the whole thing. I mean, she was in a horrible state. And then, of course, decompensated from there because she developed the pulmonary edema, and then she couldn't oxygenate, and then she got hypoxic, and then her cardiac dysfunction got worse, and so forth. I'll tell you this, from what I understood in talking to everybody that was there at this particular scene, was that everyone was moving seemingly in slow motion, but the fastest any team has ever gotten a patient on ECMO before. So I've heard it was just an absolutely perfect precision operation to get this done, and both mother and baby went home and did very, very well, continue to do well today. I wanted to show you this other slide, and this one here goes to some of your other discussions. So patient 2, and let me tell you, John, this was one of the most horrific events I've ever had in my life. 19-year-old male is his height and weight. He had recently traveled to Africa. He was unable to ventilate or oxygenate. He had extremely high peak pressures on the vent. His WBCs had plummeted. He was in septic shock. He was on multiple pressures for blood pressure, and his LV, however, was extremely hyperdynamic. The patient was put on VA ECMO, done fem-fem, okay? The flow was 4 liters a minute. The patient continued to do poorly. Severe lactic acidosis persisted. His arterial blood pressure was 120/90 with constant max pressor support. His arterial PO2 was 300. The oxygenator PO2 was 350. The pulse ox was not reading on multiple sites, neither hand, neither ear, or temporal. Okay? Now, I walked into this scene, and everyone was trying to figure out what was wrong. So the first question I asked was, where is the arterial line? And they told me it was in the femoral artery, the contralateral femoral artery. And I was like, well, this is a very big problem. So what do you think, and this goes right to your slide, what was the real problem? Keep in mind, the pulse ox will not read on multiple sites in the upper extremities.
I mean, if you're getting a real arterial blood pressure femorally, 120/90, if that's real, you know, I really don't know. I couldn't tell you exactly what's going on here.
So this is perfect. I'm so glad, because this is a perfect thing. The key indicator, John, is that they were measuring the APO2 from the femoral artery. We're fem-fem cannulated with ECMO, 4 or 5 liters of flow. The patient's LV was grossly hyperdynamic and probably had a cardiac output of 12 to 15 liters. So there's another hint.
Yeah, I mean...
so let's look at it. Well, you talked about it, John. I know you know what it is, but I don't want to belabor the point. We're flowing here. Well, they're flowing on this side, going this way. They're measuring the PO2 here.
Yeah, well,
we're flowing 4 liters this way, or 5. He's pumping 12 this way, and his lungs do not work at all.
Right. So you've got severe. Your mixing cloud is way down by the abdomen.
Classic Harlequin syndrome.
And
when
this
I
is why
finally,
I stressed.
yes, when I
This is
finally
why I-
got them to get a PO2 to stick the radial artery and get a PO2 from there, I didn't even need the PO2. The blood coming out of his right wrist was black.
So
And I'm
yesterday and today, I think I emphasized always do the right hand with a
Right,
pulse ox,
the
always
right radial, not
right
the
radial,
left,
right,
the
yeah,
right.
Pulse ox, right radial blood gas, always, always. And even if it's not a femoral artery situation, just always use the right out of habit.
Yes.
That way, one day when something like this happens, you didn't have to think to put it on the right. It's always on the right.
Right.
And so this is exactly
The thing
right.
about thing about the right radial, as you just described, is
Yep.
that it is the farthest away from the femoral artery system where you may be cannulated. And of course, we know that the first branch is the innominate, which goes to the right the right subclavian and right carotid. Then you have the left carotid. Then you have the left subclavian with the vertebral coming off of it. So if you're measuring the PO2 here, it is very likely, in fact, it's certain that the PO2 in your brain is going to be the same. However, and with that said, you still could have some down at the aortic root, right where the valve is and the coronary arteries are, could still be a little bit hypoxic. So having that LV decompressed really helps and makes a huge difference. If you have zero lung function or minimal at best, and you have no LV dysfunction at all, the last thing you do is use VA ECMO.
Yeah. When you said that the blood gas, that the radial, was 300, I'm always assuming that people are drawing the blood gas from the right.
Right. But here, look.
Anything else, you have to be very careful if it makes any sense.
Right, and that's why I said when I walked in and they said the APO2 was 300, and I said, wait a minute, where did you draw that from?
Yeah, that's a lie.
Because I didn't see any lines in the wrist, and they told me it was on the contralateral femoral artery, and you're perfusing from the oxygenator into the other femoral artery. Well, guess what? You just measure, all you're doing is measuring the oxygenator PO2 at that point in time.
That's all you're doing is drawing basically from almost what's coming right out of the femoral artery cannula.
Correct. That's why it was so close. But anyway, very good. John, this was, unfortunately, we had certain here. Look, I have this, never be this guy. Never use VA ECMO with peripheral cannulation, fem-fem, for pure pulmonary failure when there is no LV dysfunction. I think that statement, and I wrote that statement, that's my own quote, don't ever do that. Because I wrote this quote from that patient. Mm-hmm. And I believe that very seriously. That is a lesson you have to learn and never forget. And we talked about LV dysfunction. There they put the impella in. You could see the septum. Remember that slide from yesterday with that bowed out ventricular septum, and then it becomes normal again with the impella in, the difference between the right and the left side. And that's your wall. This is your
what we're talking about,
Yeah, and this is your wall tension. You see with VA ECMO how high the LV wall stress is, but with tandem and impella, it's much lower. Now, tandem and impella. Well, if you use tandem heart, you can put an oxygenator in. Impella, you can't, and it just depends. If you need oxygenation support, and not just circulatory support, or your biventricular failure. VA ECMO, I think, is a better choice than doing two impellas, a right and a left. That's just how I feel.
Something interesting with the impella that you want to talk about, Joe. Imagine that it's a constant flow. The impella's in the left ventricular chamber and a constant flow, out of the valve. Is the valve staying closed all the time? Is the valve partially open? The blood that's coming back towards the aortic valve from the femoral artery? Is that keeping the aortic valve closed, but yet there's a cannula, a large cannula, keeping the leaflets from closing all the way?
Mm-hmm.
Is there aortic insufficiency that the impella must also deal with? It's kind of an interesting, physiology all around what's happening there at the side of the aortic valve when you have an impella running.
Absolutely, I agree with you 100%. So as I told you, Juan Carlos Vasquez is who answered the question. And so this is in the femoral vein going up the right atrium. This one is in the contralateral femoral vein going up to the right atrium and then crossing over through basically through a septal perforation with a cannula into the left atrium. So it's a left atrial drain. And then you have return into the femoral artery, return to the femoral artery. So that's why these two accesses, one is dark red or blue, and the other one is bright red. And I think I have a diagram of it. There it is right there. So that was what you were talking about earlier, is how do you vent the left ventricle through a venous system?
Well, that's a great one, because I didn't include that one. I made mention of it in that little bit of a complicated slide I had, but that's a great illustration. And again, when you walk into a complicated situation and you're taking over the shift for the previous perfusionist, and you say, well, what's all going on here? Are any of these a left ventricular drain? And usually when you have a complicated ECMO, most of the time there is some form of a left atrial, left ventricular, some drain that is part of the hybrid ECMO, and that helps you now digest what. Now you've eliminated one, so you're down to either 2 or 3 more that you can basically understand. From my second question I want you to ask is, are we just overcoming difficult flows with the others? And then you've got a real good concept of why we have so many cannulas going in and out of this patient.
Yes, absolutely. You have access to take into consideration. You have return to take into consideration. You have where are you accessing it from and what's going to give you the best drainage to accomplish what your goal is. If the goal is to eliminate as best as possible flow from the right side to the left side through the native circulation, then you really want big access. If your goal is to return to multiple, sites to overcome a heart that may be working okay, then you have to start thinking about, okay, the lungs are bad, the heart's working okay, I've got to worry about dual circulation. Let's do VAV and or VVA, however you want to say it.
Right.
So you really do have to think it through, and you need to look at the circulation and sort of draw it out in your head and think about, okay, where is this going and what are going to be the forces that are going to be working either to my favor or advantage, and what's going to be working to my disadvantage and working against me. And that takes some skill, and I think that just goes full circle all the way back to the idea of ECMO specialists and perfusion, and why I think we need to advocate for blended programs. We need manpower, but when it comes to understanding these things, just simply because of our experience in the operating room that we do every day, I don't think you can find anyone more capable on a large scale, numbers of people capable of managing ECMOs than perfusion. But that's not to say you can't teach people this and they can't learn it. It's just that we have the experience from our training on every day. And at the ECMO specialist, though very smart and very capable and very able to learn, takes some time, because you and I can look at something and immediately know what is wrong or what can we do to fix it.
Well, you make a great point about drawing it out. And I tell you, that even at where I'm at now, which is a very busy ECMO place, and I go to a very busy ECMO place every now and then as a traveler up in the Northeast, and it's an Ivy League type of place. They have very, very decades of seasoned perfusionists, and they draw every one of their ECMO configurations out, even though they've seen it 1,000 times. And so over time, they've got a whole book of these drawings. They literally have, 30 or 40 of these things of configurations. But no matter how many years you've been doing this, if you really want to gain an understanding where you can do it in your sleep, do this for a while. Make a drawing of every one that you do for a while. And if it's the same one over and over, of course you don't need to. But every time you see something different, get a plain heart diagram. You can download one off the internet and draw in the cannulas and put a little arrow where they're going and what's happening. And it'll help you. It sounds basic, but it'll help you. And the digestion, the way your brain will work around it is you'll get to the point where you won't need to do that. You'll look at a patient and you'll know exactly where the pressure issues are, where the problem solving comes in, because you've thought of this through, and you've looked at it on paper.
Absolutely. Okay, so John, I'll bet you that you are questioning your sanity for having agreed to participate in so many of our programs, and I know we are looking forward to Monday, where you're going to be discussing blood transfusions, the good, the bad, and the ugly. I think blood transfusions get a bad rap, and I think that anemia is far worse than the risk of transfusions. But I'm sure I'll have a lot of questions for you on that topic as well. And
I didn't sign up for that one. That I'm looking at my list, but okay.
Oh, yeah, I thought you did. It's on your list.
I don't know. I'm looking at a list here, and I signed up for May 7th pH and alpha stat. May 8th, roller versus centrifugal, and then May 12th, goal directed. But maybe you have something different.
I do, but you know what? It's okay. I can give that talk. I mean, I can give it. So
I'll tell you what. Let's work on it together. I'll put together at least 15 or 20 slides, and you do it, and we'll tag team it a little bit.
I think that sounds like a lot of fun. John, it's always a pleasure to work with you, and it's I know our audience truly appreciates your wisdom and your expertise, and also your delivery. I think you do you do an incredible job at these programs, and we can't thank you enough for your willingness, as I said before, to take time out of your busy schedule to do this. So we'll see you on Monday.
All right, Joe. We'll look forward to it. Thank you.
Thank you, sir. Bye-bye. And everybody else, we'll see you on Monday as well, at same time, same channel, and by Monday, I promise I'm going to have this problem solved, and it will never happen again. Or I swear I am going to throw that box out the window, and then there just won't be a program. So we'll see you on Monday, same time, same station. And congratulations, Juan Carlos Vasquez. Get me your address. I sent you the email address at contact@perfusioneducation.com. You get 2 of these cups all the way to Argentina, and I want a picture of. In fact, you're going to come on the show and show us you drinking your coffee. So take care, everyone, and thank you all very much.
The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOT device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. This is just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the epoch that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the epoch device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perfusion, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EZ-Flow Duo. For arterial direct and venous femoral cannulation, the EZ-Flow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EZ-Flow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EZ-Flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.